like to thank the organizers uh, for giving me this opportunity to delve on a topic which is the newest in renal cell carcinoma, that is the adjuvant treatment in RCC. Something which was a misnomer earlier, and now slowly in urogenital tumors, in RCC, in urinary bladder cancer, everywhere adjuvant IO is now gaining a forte. So with that preamble, first I'll be dealing with the adjuvant treatment in RCC. So you have a host of trials with VEGF or TKIs. All of us know that you have sunitinib, you have pazopanib, you have axitinib. But then, unfortunately, if you see, but if you just see the efficacy, you'll find that apart from just one, that is the second one where you had only a disease-free survival benefit, all the others failed. There was no survival benefit. And mind you, when you use TKIs, you have only DFS benefit, you don't have the overall survival benefit. So once you have only the DFS benefit, the use of TKIs in the adjuvant setting has been associated with toxicity concerns and high rates of treatment discontinuations. So, in early stage disease, patients may be less willing to accept this toxicity. And as of now, if you see, TKIs are not being used in the adjuvant setting in RCC. So, when that was the situation, what is the rationale for immunotherapy in adjuvant RCC? Well, they target the PD-1, PD-L1 and the CTLA-4, and adjuvant therapy has a significant benefit in patients with malignant melanoma. So taking a corollary from that, there were a lot of trials which were done in the adjuvant setting. And here you find atezolizumab, nivolumab plus ipilimumab, and you have nivolumab and also the durvalumab. So you have two trials which is IO plus IO, and there are trials which have IO only. So these were the key trials in the adjuvant space. And amongst this, the only trial which has come positive is the first one, that is the Keynote 564, which is here on the top. So we'll be discussing about this. So this was in patients who were histologically confirmed clear cell carcinoma. They were the patients who had undergone nephrectomy. There was no previous systemic therapy. They were in good PS, that is 0 to 1. And the primary endpoint was disease-free survival. So these patients were given pembrolizumab versus placebo over a period of 1 year, every 3 weekly. And the cases which were included in the adjuvant setting were patients who had T2 to T4, or the patients who had node positivity, or there was a new entity which was M1NED. M1NED is those patients who had metastatic disease at presentation, but after surgery, all the metastatic sites were removed. And this should have been within 1 year after nephrectomy. So you have T2 to T4, you have node positivity, and you have M1NED disease, in which there is complete resection within 1 year after nephrectomy. So this met the disease-free survival in the intent to treat population, where you can see that even after 2 years, 78% were alive versus 67%. And also when you see across the risk groups, whether it is the high risk, intermediate high, or the M1NED, there was a benefit, meaning thereby whether it was M1NED node positive or it was T3, T4. The overall survival, the events have not matured till now, so the data is not out yet, but there is a trend towards the OS, and so there is a trend towards the metastasis-free survival in the intent to treat population. But since we have only the disease-free survival in these patients, there are concerns. You have to give this drug for 1 year. It may have its own potential toxic effects. And when they occur, these patients are the ones who are subjected to steroids over a long period of time, then unfortunately we don't have the predictive biomarkers. The clinical trial endpoint in this is disease-free survival only. It is not overall survival. Had it been overall survival, it would have been more robust. But having said that, this is the study which has proved that you have a DFS benefit in patients who are adjuvant post-surgery. Along with that, there can be other concerns. I had mentioned 3 or 4 trials, but you can see there is a immuno-oncology drug variation. When you use pembrolizumab, you have the benefit. When you use ipilimumab and nivolumab, or you use perioperative nivolumab, you find that there is no benefit. Now, why is it so? This is because of the population heterogeneity in these trials. For instance, if you see the trial which was successful, that is the Pembro, which is in red, you find that most of the patients were T3, T4. But when you see the other trials, say for example, atezolizumab, that is the iMotion trial, you find that they have included metastatic cases also, they have included sarcomatoid also, and T3, T4 are not there. So because of this heterogeneity, probably that is the reason why the other trials failed and this trial could gain forte. Again, definition of M1 NED. M1 NED means no evidence. So if this definition was extrapolated to iMotion 1 in which atezolizumab was there, the definition was totally different. So these were the caveats. So suffice to say that the known facts are that the addition of pembrolizumab for adjuvant RCC is a new indication. Hastening accruals don't always lead to faster answers but missed opportunities. So when I say that, I mean that I'm waiting for the overall survival data, which is not there. We only have the DFS data. And of course, shared decision making is the key. So the patients who are most benefited are the ones who have T3, T4, node positive disease and the M1 NED. So this was the known. What is unknown? Long-term OS data is not known. One cannot abandon the neoadjuvant approach, although the perioperative nivolumab trial was negative. Are we over-treating or under-treating these patients? Because some of these patients, that is about 25 to 30%, can still have a healthy life even in the metastatic setting. And of course, the impact of quality of life when these people come under the purview of the side effects of the immuno-oncology drugs. And of course, unfortunately, we don't have any relevant biomarkers in RCC, which is the burning question, because we have to back on, the risk stratification only. Again, you have the unknown, you have the known, then what are the challenges? Difference in the outcomes across trials are due to trial-specific factors, which I have just now alluded. Short-term and long-term treatment risk must be ascertained. Under-treatment in adjuvant setting as against the combination therapy in the metastatic setting, again, is a question which remains to be answered because there is no study where you have a combination of IO plus TKI in the adjuvant setting. And duration, whether 1 year is enough, whether it is less or more, that again is a problem when you treat these patients for 1 year. And of course, as all of us in the SARC group are in the resource crunch, this forms a major problem, the finances, when you give it for 1 year. So this was the adjuvant setting. Now switching gears, coming to the metastatic first-line RCC. For instance, there is a case of 51 years who underwent nephrectomy, who had KPS of 60, calcium of 8 milligrams. So here, a case when it comes to the OPD, what do you do? Is risk stratification important? So just now I mentioned that in the absence of biomarkers, this is the only thing by which we can bank on whenever we treat these patients. And based on this, the NCCN criteria have been placed. And if you have a patient who has a good risk or an intermediate or a poor risk, based on these factors, this is the IMDC criteria here, we can treat these patients. So if you have a patient who has a favorable risk, no prognostic factors, that is none of these, intermediate can be one or two of these. Poor risk is if you have more than 3 factors. Why it is important? Because the survival of these patients depends on the risk stratification. If you have a good risk patient, he or she may survive for years. If you have a poor risk patient, that patient will only survive for a few months to probably 1 year. So that way we can prognosticate the patient. And we have a plethora of choices here. We have combination of IO plus TKI, that is, it can be pembrolizumab, nivolumab, or the combination with exitinib, lenvatinib, or cabozantinib. This was again pitted against the current standard, which was sunitinib. And this, as I told you, has been incorporated in the NCCN guidelines. If you have a favorable risk where you don't have any of these factors, then in these patients you can give IO plus TKI. If you have poor or intermediate risk, in these patients you can add ipilimumab and nivolumab, that is IO plus IO, which is category 1 in poor and intermediate risk groups. Rationale for combining the VEGF plus IO, this leads to the priming, which may be better for the PD-L1 therapy when you add the TKIs to these. So question comes is, why do we use VEGF as a target? So this is just to go slightly into the depth. VEGF pathways are always there in the body. They occur as a physiological response, whether it is wound healing or whether it is menstruation or whether it is embryonic development. But when this system goes haywire, you can have an overexpression of these VEGF pathways, which again can lead to a pathological response, or which is seen in RCC, colon, and a host of cancers which I have shown you here. So angiogenesis per se, it is expressed by VEGF in the tumor itself. It can be because of hypoxia. It can be because of certain factors which are PDGF, that is platelet-derived growth factor, or the insulin growth factor, or the epithelial growth factors. So how it occurs is that you have a pre-malignant state, and at this point of time, once the tumor gets a foothold by getting vascular supply, this is known as the angiogenic switch. So once you have the angiogenic switch, that leads to the metastasis. And if you give the VEGF, you can block that and you can lead to the apoptosis. So if you explained it very crudely with this example, so this you see is the cell membrane. Here you have the transcription going on. The signal travels from outside the cell into the cytosol because they cannot directly go through the cell membrane, which is a very resilient structure. So whenever there is an overexpression of the VEGF receptors, what happens is there is a signaling into the nucleus, and that leads to the tumor proliferation. So this is in a very crude form how a VEGF works. So there is an evolving approach to cancer therapy, and along with that, now you are targeting these cancer cells with the immunotherapy drugs, and that is by the T cell activation, which is done by the checkpoint inhibitors, in which the inactive T cell is sensitized by the antigen presenting cell, and that again goes and kills the tumor cells and leads to the apoptosis. The drugs and the combinations which are there, we are now spoiled for choices in RCC in the first line metastatic setting. You have about 4 combinations which are like lenvatinib and pembrolizumab, that is IO plus TKI. Again, pembrolizumab and exitinib, which is IO plus TKI. Then you have IPI and Nivo, this is IO plus IO. And of course, you have nivolumab plus cabozantinib and exitinib and avelumab. So you have 4 combinations which are IO plus TKI, and you have 1 combination with IO plus IO. And here, this was something which was never seen in the metastatic setting. Complete response rates you have ranging from about 9% to about 16%. Maximum is with lenvatinib and pembrolizumab. Earlier, we used to only talk of control. Here, you are talking of disease eradication in the metastatic setting. So, by the addition of the immuno-oncology drugs plus VEGF inhibitors, you may have complete eradication in about 10 to 15% of cases. And this is just to show you the trials which are there. This is pembrolizumab and exitinib with sunitinib. You find that even in the good risk, poor risk patients, there is an improvement in the overall response rates. This is the second trial, nivolumab and cabozantinib, which was pitted against sunitinib, and that also showed that OS at 2 years was much better, which you can see the splaying of the curves, which is here in the PFS and the OS. Third trial is the avelumab and axitinib, which is again in treatment naive advanced RCC, in which IO plus TKI was pitted against sunitinib, and that showed a PFS benefit in the intent to treat population. You have the immuno-oncology plus immuno-oncology drug, that is ipilimumab and nivolumab, and this was given in patients who were poor risk or who were intermediate risk, and they again showed that in these two there was a difference in the survival, but not in the favorable risk, where you can see the graphs are going together. So if you have to give IO plus TKI, you can give in all the three risk stratifications. If you have to give IO plus IO, you have to give in intermediate or poor and not in the good risk. And this was the last study, which is the latest which has come, that is lenvatinib plus pembrolizumab. And this, what I was showing was there was a complete response of 16%, which was never seen earlier. This is the highest response which is there in the IO plus TKI category, which was hovering around 9 or 10% earlier. And this is just to show an example. We have a lot of patients. This is a patient of metastatic RCC, a young guy who came to the casualty. He was panting, he had effusion, he had a mass lesion there, and we started treating him, and he has improved after post 4 cycles. This is just a chest x-ray, and now he comes walking to the clinic. So that is what you call quality of life. So he was given nivolumab. This was as second line. So when you use VEGF, sunitinib or pazopanib as first line, you can give single agent IO in the second line. And he was a poor risk candidate. So to summarize, risk stratification in the absence of biomarkers in metastatic RCC is the most important parameter to choose for the right treatment option. Good risk patients and those with favorable intermediate risk can have survival of many years. So you have to choose very carefully how you go about when you treat these patients. Availability of new immuno-oncology combinations, I told you IO plus TKI, or you can have IO plus IO, are creating a paradigm shift, meaning thereby the complete response rates, which were about 6 to 9%, they have now jumped up to 16%. So whenever a patient comes to you in the OPD, first thing is you have to stage the patient. Next is you have to do the risk stratification. And once you have done the risk stratification, then the treatment becomes very simple. Whether you have to give IO plus TKI or whether you have to give IO plus IO, or if it is in a resource crunch countries like India and Bangladesh, then probably we can give single agent TKIs in patients who are good risk. So I think I'll stop here. I thank you for your patience here.